Okay, I am going to be just sharing the screen. So guess what? You do not need to see my face. I don't want to, have to record every single time and have my face up there in that corner. I keep forgetting about the fact that I can do it this way. One thing I wanted to talk about first before I start on chapter 4 is you all are doing a great job on your homework, and I'm really enjoying seeing faces. I'm enjoying learning about people. The stereotypes one has been quite interesting because what I have been appreciating are the individuals who are saying, I just want to preface this with, I do not hold any of these thoughts or any of these stereotypes. I don't believe these things. This is just part of the assignment. I appreciate that. I really do. That is a step in a good direction, isn't it? Where we don't want to necessarily say that we tend to agree with certain stereotypes. So yeah, excellent work. All right. Starting with chapter 4, we're going to be looking at physical changes with older adults. And this is the one aspect of aging that we tend to focus a lot on, and in a good way, in a bad way. In a good way, where we can appreciate our individual differences. In a bad way, that we are not appreciating our individual differences, and we think that we should all be looking the same, more of a homogenous aging process, where if it works for one person, it's going to work for the next person, as opposed to, well, what are the genetics that I have going on for me? Or what are some of my risk factors? Or what are some of the things that I do that might cause me to lose my hair? Or what are some of the things that I do that might cause my skin to wrinkle more around my mouth? Maybe that's cigarette smoking. Those types of things. So those are, when we focus on the physical changes of older adults, we're going to be talking about it from mostly appearance, and looking at why some things happen and why some things aren't necessarily linked to the aging process and are more linked to genetics. All right. So our physical changes, we are first going to be focusing on the skin and the hair, because let's face it, when we start looking at ourselves in the mirror, we might start noticing those laugh lines, those little crinkles around our eyes, the forehead creases. I always rest my glasses on my forehead. I have 2 indentations on my forehead where my glasses just naturally go, and it's because of the nose piece. And I've done that to myself. It's something that I've created, and it's now a part of my physical appearance. Is it because I'm growing old? It might be because my skin is changing. The skin elasticity, the lack of collagen in my skin might be the reason why that happens. My wrinkles, because I smile a lot and I smile with my eyes. I don't know if any of you are doing this. I've seen a couple of comments about this, about how you try to smile like crazy behind your mask during this pandemic, just so people know that you're smiling behind the mask. So you try to do it more with your eyes. We might start seeing more wrinkles around the eyes because of that. I have the laugh lines, all of that stuff. Is it because I am growing older? Possibly. It could also be because I smile a lot. So when we look at our skin, this is a comparison between younger and older skin, and it's a cross section. First, we look over here on the left under younger. We have a thick epidermis. Our subcutaneous fat layer is pretty evenly distributed throughout the area. And then we look over here on the other side, the right side, with our older adults. And the major changes that we see, number one, we see an age spot. That could be due to photoaging, which is going to be damage to the skin, which is a result of that sun exposure. And remember, as I said in one of the last chapters, talking about primary, secondary, and tertiary aging, with our primary aging being age spots. That's just a primary aging thing, because we may have received some damage to our skin because of being out in the sun. Where that moves into secondary aging is if those age spots and that damage to the skin then forms into some kind of a melanoma or a skin cancer, and then we have secondary aging in that cancer that we may develop. The loss of skin, or within the loss of skin, loss of skin elasticity, there you go, not loss of skin, loss of skin elasticity, we have collagen and under our skin, and we are and elastin as well. While we're younger, it's supple, it's flexible, it's, it springs back, it does what it's supposed to do. But as we grow older, what we might start noticing is our skin appears to be a little more paper thin. We can see veins a little bit more. We may bruise a little bit easier. We may also not recover from scratches or scrapes as easily as we did when we were younger. And that's due to that loss of that skin elasticity, excuse me. And then we have the subcutaneous fat. It starts to sink a little bit. So you might notice skin that looks like it's sagging and a little flabby around the arm area, especially with older adults. If there's not muscle underneath there and that muscle mass isn't being attended to, then we can have that subcutaneous fat just kind of drift down toward the middle of that skin and then leave that skin behind, and it's a little looser and a little flabbier, and that might be the reason why that we see that. And as I said before, just a little bit ago, talking about cigarette smoke, I don't smoke cigarettes, I don't smoke at all. But for some, cigarette smoking can cause skin damage around the area. It can also cause different wrinkles to form around the mouth. Think about what skin looks like with holding the cigarettes. And yeah, there are a number of different ways that cigarette smoking can cause damage to that skin. Then we have our hair. And this doesn't deal necessarily with the color of our hair. This deals with the baldness that may occur. Typically, when we see male pattern or female pattern baldness, it's due to alopecia. It's not due to the fact that you're growing older. It kind of goes hand in hand, but it's more due to genetics. Okay, so if you live long enough, the genetic predisposition to male or female pattern baldness can start to show as we grow older, okay? And these are just the different scales, the Ludwig scale and the Hamilton-Norwood scale that are used in male pattern and female pattern baldness. But it's called, basically it shows baldness that occurs from androgenetic alopecia. And that is a genetic predisposition to developing that. All right, our body build. We need to pay attention to our height and our weight, right? When we are, as we age throughout the process. Well, obviously we can't do too much about our height, but it's something that we look at with older adults. Many people will notice grandma is shrinking. And I don't say that flippantly. I don't say that tongue in cheek. I say that with true intention of drawing attention to the decrease in height for women. And that may be due to the loss of bone mineral content in their vertebrae. So while it might seem silly to think that we have a shrinking individual, we have seen that does occur with that bone mineral content loss. Our weight, our free fat mass decrease. So the free fat that we have, it's just fat that's just roaming around, and it starts to decrease as we grow older. Our BMI might change as well, where if we are in a certain range on BMI, we might go up or we might go down in BMI. But we do tend to see some weight decline very late in life, not due to any kind of secondary aging or tertiary aging reasons, just due to primary aging, just that we might not be as active, we might not be eating as much, our body composition shifts, it becomes a little bit different. We start to metabolize things a little bit differently, especially with medications. And the big primary thing, medications can really make a difference with somebody's weight. It could cause them to gain weight, it could cause them to lose weight. They may not have much of an appetite. So it's all of those things that we can pay attention. But we have a big running joke around our house. Anytime there's a news story on, we always joke that the answer is diet and exercise. So how can we stave off Alzheimer's disease? Diet and exercise. How can we take care of mild cognitive impairment? Diet and exercise. How can we address your increased chance of developing this type of cancer? Diet and exercise. Exercise can offset these trends with your height and your weight. Obviously, we know that. That's really something that we don't necessarily have to talk about, because a lot of times it's either overlooked or it's not taken on because we don't think that it really matters that much. But diet and exercise all the way throughout our lives is obviously important. It's going to have a big effect, and it can also boost your well-being. And if you think about older adults who might want to continue to feel as well as they possibly can, they may continue to exercise in the same manner that they were. They may take up some new exercise programs. This is just an example of what are some of the exercise recommendations for endurance, resistance, and flexibility. Obviously, with endurance, we're talking about walking or swimming or biking. Resistance, that resistance training, how many times that we work our muscle groups. And then flexibility are those sustained stretches. So think about like yoga being in flexibility. Yoga can also be in resistance. If we are swimming so many laps, that's our endurance. But we're also working some muscle groups, so that the water would be giving us resistance. So it's just different concepts of this exercise recommendation, and just looking at it, not necessarily from the aging population, but from all across. And then we also, we focus on the physical aspects of aging. We also look at how well somebody's able to mobilize, and are they able to get around the way that they want to? Do they need some assistance? And we need to pay attention to our muscles, our bones, and our joints in that process. Here is an example of different age-related changes that we start to see in those muscles and those bones and in those joints. Muscle, our big word is sarcopenia. And for those of you who are exercise physiology or exercise science, you probably have had this word thrown at you so many times throughout your process. For those of you who have never heard of this word, you are now introduced to it. Sarcopenia is when we start to see that change in our muscle mass as we grow older. Where you can see with a young individual, that would be the arm. I think that's the way that looks. Yes. So there, I am no anatomy and physiology person. So those of you who have had A&P, you can name off what those things are there in that little diagram. But you can see where that one muscle group is much smaller, or actually a couple of muscle groups there is much smaller. Well, actually about all of them that are listed there are much smaller. And it's that concept of use it or lose it, right? You have to use it in order to keep it. And if you don't use it, you lose it. This comes in the form of individuals who might have a hip issue. If they are not mobilizing and they're not using that hip as they should, the muscles around the surrounding area are not going to be able to support the activity that once was had by that individual if they continue to sit on the couch. If you have somebody who has a sedentary lifestyle, they're not using a lot of their muscle groups, and we have an issue with that. I also want you to think about grip strength, and this is a good indication in these two models. As far as grip strength is concerned, think about what's important for you when you're walking, and especially if you have a walker or a cane. If you are missing, or your muscle groups are so much smaller than they normally have been, or if it's like the old on one side, but your other side might look a little more young, and you have like a disparity in your muscle size, that can make a big difference for somebody's quality of life. If they can't carry in groceries on one arm but can on the other, they're always going to use the arm that they can carry the groceries in on. If they are using a walker and their grip strength is not very strong on one side, they may lean over to the other side because that's their stronger side. And then you have a disparity in that gait and in that walking. Our bones, where we discussed with older women losing their height, this is what those bones would look like with that loss of mineral content. And where we see that a lot is with osteoporosis. Osteoporosis being caused by especially a hormone fluctuation, and that's a primary reason. And we see that mostly with post-menopausal women. And then our lovely joints. I mentioned a hip, knee, shoulder. Think about those places that those joints are. And if we start to lose that cartilage in those areas and it's bone on bone, we may need to have a joint replacement of some sort. But those are certainly things that would have to be addressed, and that it can be age related. It also can be injury related. It could be sports injury related. I'll go back to this. I had my hip replaced when I was 38 years old, my left hip, but that was congenital. It was a birth defect. And so does it make me an old person because I had my hip replaced? Well, I certainly hope not at 38, but those are typically seen to be an older adult issue, but it really is just all part of the larger aging process. I'm not going to go too in depth with the vital bodily functions because I feel like those of you who are in A&P will get much better information as far as how these systems work, but this is just in the context of what happens in the aging process with these systems. Obviously, with our cardiovascular system, we start to see a major change in the arteries, because what we see is about a 1% change per year decrease in our aerobic capacity, and that is from young to old. And we might start to see that in how well we are able to participate in any kind of activities. Our lungs might decrease in their volume. And so my students who have taken psychology of aging, for those of you who actually were able to do the aging suit simulation, I had one section that had to kind of stop in the middle when we released with COVID, not released with COVID, but when we released because of COVID. They had to wear a weighted vest, and the weighted vest was to simulate this decrease in their volume in their lungs, to make it feel like they were having some not breathing issues, but that there were some restrictions on their ability to breathe as they normally would. Within our kidneys, we might see lower rates of excretion, and the kidneys are not going to function as they once did. So this is just this in word form. As far as what we can do with our cardiovascular, our respiratory, what we can do to prevent and to also compensate for issues that might arise. Lower maintenance of aerobic capacity, or longer maintenance of aerobic capacity, meaning you should be exercising and should be engaging in some kind of aerobic exercise throughout your life. And it can be in a different form. It might not look like what you used to do when you were 20, but at least you are still keeping up with that diet or that exercise component. We also need to pay attention to our blood pressure. If we have a propensity to have high blood pressure, we need to have a conversation with our practitioner and say, you know what do we need to do? That might be, well, you probably could stand to lose a few pounds. If you lose so many pounds, you can lower your blood pressure by this many points, or we may have to go the route of medication. And many individuals do have to go that route because it's just something they can't control themselves. And also paying attention to our cholesterol. Respiratory, if you're smoking, if you can, quit smoking, or if you haven't, don't do it. Those are my words of advice, obviously. A very personal statement, but regulating your body weight, those of you who have seen me, that's one area that I could obviously pay attention to. And also exercise to strengthen your chest wall. So if you're working in this upper area of your body, that you can work on strengthening kind of that core, that chest wall area. Avoid or quit smoking. Do you notice it's a diet, exercise, and don't smoke. All right, avoid or quit smoking. Also pay attention to your medication doses. If you are over medicating on certain areas, then like say, for example, if you're taking a diuretic and the diuretic is not making you go to the bathroom like it should be, you need to talk to your doctor about that. And typically diuretics are given as part of a blood pressure medication regimen. Yeah, overactive bladder or incontinence, those things can happen to the best of us. For those of us who might happen to have children and have our own children, females I'm speaking of, know that incontinence and bladder control is an issue, and it can be an issue throughout life. Medication can also cause some incontinence in some bladder situations. And our digestive system, sorry about that, down there in the bottom where it says lifestyle factors play an important role. That's down there in that area. I really can't read that well. There are some minor changes with growing older. The top three are the ones that are seen most prevalently. We don't really see a lot of age-related changes in the digestive system, but we can see some. Typically, when we have digestive system issues, we've had them for a majority of our lives. GERD or, well, yeah, all I can think of is GERD right now, and that's gastro, and I can't think, esophageal reflux disorder, possibly. I don't know. I made that completely up, but it's something, it's heartburn, major heartburn, and where the stomach acid burps back up into your esophagus and can cause major heartburn and some major discomfort and also some damage as well. But typically, as far as age related is concerned, GERD doesn't just all of a sudden say, oh, you're 65, here I am, right? Fecal incontinence can occur to about 4% of the population, those 65 and older, and that can be controlled by diet, and it can also be controlled by some medications as well. So knowing that those are issues that could possibly come up as far as the aging population is concerned. All right, then our endocrine and our immune systems. Our endocrine system being those hormones, the growth hormones that we have, where we start to see some decreases in some areas. The one that I want you to pay attention to the most is this fourth one, which is melatonin. Melatonin is that lovely little hormone that drops to allow you to go to sleep, right? And I know that many of you know, if not all of you, that when you're going to sleep, they always say, don't have your phone on. That blue light won't let your melatonin drop. Then you're going to remain awake. Always put your phone over to the, on another table, or turn your phone completely off. Okay, so those are those types of situations. But if, as you grow older, it does decline, that dropping of the melatonin, which can then mess up your circadian rhythms. And once you mess up your circadian rhythms, then you are, think of it like a baby. Babies who are just newly born don't know a difference between night and day. And they think at 3 o'clock in the morning, it's time to get up and eat. And some babies get really thrown off. Their circadian rhythm is thrown off. It can happen to older adults as well. A number of factors can go into play with that, but this one discussing melatonin is one of the big ones. And so you'll see a lot of times like natural supplements with melatonin in it to help increase that production, especially with older adults who might be having some sleeping issues. There can be other reasons that they have sleeping issues, and it could be medication, it could be disease, it could be just sleeping during the day when you probably shouldn't be sleeping during the day and taking longer naps. So, all right. Okay, that's really good. I forgot I had the same slide. Yeah, so just go through that second slide. Act like you didn't see it. Menopause and andropause. Menopause being the individual being female is no longer having a period. There can be perimenopause, menopause, and then postmenopause. Perimenopause can occur between 4 to 10 years before menopause occurs. Menopause, you have to not have had your period for a year. And then there are going to be some changes that occur. Typically, during that time, women suffer from hot flashes. There are also some increased risks of cardiovascular disease, as we've said before, with bone density and bone mineral content. That can change as well. There is a a usage of hormone replacement therapy that some individuals take on and say, I'm doing this. And some individuals say, I am not touching that with a 10-foot pole. That's all personal choice. There are benefits to HRT and there are some downfalls, some detriment of using HRT. It just is individual choice. There might be some alternative ways to handle menopause: exercise. Here we go again. Exercise, lower cholesterol, diet, having 1 alcoholic drink a day, diet, stop smoking. There you go. Okay. So it's a theme. Andropause is when there is a change in the male hormone of testosterone. There's about a decline of testosterone about 1% per year, which is also called late onset hypogonadism. Okay, that's a big old mouthful right there. It can happen more likely in men who are diabetic or they are obese, and we start to see more of an increased use of testosterone supplements to help that. It's called the T cells. Okay, and not T cells. Is it T cells? Low T, that's it. So not T cells. Good Lord Almighty, don't say T cells. Anyway, low T, low testosterone. You'll see some supplements that are out there, and you might have seen them on some commercials where they are addressing that low testosterone. And what that can translate into is erectile dysfunction, or ED. And that can be increasingly common for individuals over the age of 65. About 44% of those males over the age of 65 suffer from erectile dysfunction. All right, there's my T cells. I knew they were on there somewhere. This is just looking at our immune system, and I'm not really going to get too much into this. Just know that there are going to be inter-individuality differences, variability in the aging process. Oh, hi, sorry, my finger got on that. Nervous system, the central nervous system. And I want to talk mostly about sleep and temperature control. Okay. So you can just read through this. This is just some information talking about plasticity of the aging brain. And if we look at age-related declines, then we start to see maybe there's some loss of the functioning in specific brain regions, might be due to some kind of neuronal loss, might be due to some changes in our neurotransmitters. Medications might affect that. Then also, here we go again, our sedentary lifestyle can affect that. Misuse or disuse of those, of your brain, really, if you're not necessarily using it in the same manner as you used to. If you think about an individual who has been a surgeon for, most of his or her life, their life, and they get to retirement and they are no longer using the brain in the same exact way as they used to, and it can become a difference in the plasticity of their brain. We might see those changes being affected, or the changes that are affecting the brain can be addressed by exercising more, having more physical exercise, the diet, as well as mental engagement. A surgeon who stops surgery and goes and becomes a couch potato obviously is not going to be mentally engaging themselves, but a surgeon who stops surgery and engages in a more creative manner, is using the brain maybe in a different way, and is getting in touch with the creative side of their nature, then you're not going to really see that plasticity of the brain occurring as much, and you won't see an age-related decline. So I talked about this with melatonin, with sleep. It's being affected by lifestyle, or it might be affected by physical conditions. There might be times where you're awakened more during the night. It might be because the individual has to get up and go to the bathroom. It could be because they just wake up and they can't get back to sleep. It's more important that we start focusing on the sleep health of older adults, because it can affect so much with an older adult. An older adult can mask depression symptoms by looking like they're not getting enough sleep, and vice versa. Sleep issues can mask depression. And so it's very important that the sleep patterns and the sleep rhythms and the sleep health of older adults is adequately addressed, especially in just a basic general practitioner workup with the older adult, that they can have a discussion about their sleep schedule. How well do you sleep? When you sleep, how much are you up during the night? What do you do during the night? And just really address all of those patterns. Maybe the person gets up and goes downstairs and eats. Well, then your digestive system really shouldn't be eating at 3 o'clock in the morning, and then you go back upstairs and lay back down, because then you're lying prone, and all of that is just lying in there, and the digestive system can't work as well when you are in a prone position. So it's just a lot of different things with sleep that need to be addressed with older adults. This is just an example of, or not example, a chart of what it looks like when our melatonin releases and our core body temperature is, it changes within our older adults. So the older adults, that's our solid line. And that shows how our melatonin releases just differently than younger adults do, and that is the dashed line. So where we think that, oh, well, I used to sleep like a baby when I was 20 years old. Why can't I sleep like a baby now that I'm 60? Well, it's because of these reasons. Your melatonin is dropping at a different time, and you have a different sleep schedule, a different circadian rhythm. Okay, vision, hearing, balance, smell, and taste, and your somatosensory system. Gosh, I can't talk today. Vision, I talk a lot about this with psychology of aging, because we do this with our aging suit experiment, but I'm just going to touch on these really quick. Presbyopia is going to be a normal age-related change in our eyesight. We can't see or focus on near objects as well. The diseases that we see with older adults within the eyes: cataracts, age-related macular degeneration, and glaucoma, where we have a loss of our peripheral vision with glaucoma. Cataracts are operable. Glaucoma is not. Glaucoma is a disease that can occur at any age, really, but for the most part with older adults and glaucoma, it's that loss of that peripheral vision. Presbyopia, this is where you're going to see somebody getting reading glasses, and they need to have that so they aren't holding whatever it is all the way out to the end of their arm so they can see it. This is old, so this is 20 years or 10 years old, but looking at the prevalence of cataracts by race for the older adult population, about 18% of the white older adult population have cataracts, Black population 13%, Hispanic 11.8%, typically, and for overall about 17% of the older adult population has been diagnosed with cataracts. Hearing, loss of the ability to hear high-pitched tones, that's our presbycusis. Tinnitus is that ringing in the ears. If we have a exposure that is increased to that excess noise, that's the most common reason for hearing loss. So if we are in an industry where there's always noise in the background, that can cause hearing loss. If we have an office that is around a construction site for that prolonged period of time, that can cause hearing loss. So it's those types of issues that need to be addressed when we're discussing hearing. This is just an idea of the decibels and what the decibel range is, that we need to be able to appreciate how loud things can be. So a gunshot or fireworks, I don't know about where you all are, but in Findlay, the fireworks have been going on since about the time that the city said we're no longer having a fireworks display. It's like everybody said, oh, well, now it's my duty to entertain the city of Findlay with my fireworks display since June. Not that I have these going off right beside my house, but last night, being July 4th, it seemed like there were at least 4 to 5 different fireworks going off in 4 to 5 different directions. They're loud, and it shows here, they're 140 decibels. If you are exposed to that for 8 hours a day, that's going to cause that harm. Raindrops still has a decibel amount, but it's very little. But here we see concerts, chainsaws, iPod. I appreciate that. Y'all know that iPods, this is probably like back in like 2014 or something. But if you have your phone turned all the way up and you got your headphones in, yeah, well, there you go. 115 decibels. Jackhammers, hair dryers, city traffic, and then normal conversation is about 60 decibels. So we have some communication strategies that we can use to talk to older adults. We can look at them while we're speaking to them. We can minimize that background noise. Don't chew gum while you're talking. That's really kind of a no-brainer. Don't do that no matter what, because that's so distracting. But don't chew gum while you're talking. Keep your voice pitch low. When I was growing up, I had a great aunt. Her name was Fern. Fern couldn't hear. When somebody would get on the phone with her, she couldn't hear. My mom always made me call Aunt Fern because I, if you can't tell, have a very low pitch voice, whereas her voice was up higher. And whenever Aunt Fern would get her on the phone, I don't know if it was Fern and my mom or what the deal was, but Aunt Fern couldn't hear my mom at all. Not at all. She was like, "Who is this?" Either that or she was just playing head games with my mother, which could be possible too. But my mom would hand the phone over to me and say, "Ask for your father," because my dad would be over there visiting. So keeping your voice pitch low is a way to also talk to older adults. Enunciate, but don't talk to them like this. Or don't talk to them like this. "How are you doing today? I hope everything's going well for you." That's talking to them like they're a child, right? Don't baby speak, people. That's just, don't do it. And so, "How's Mrs. Johnson?" Okay, so how's Mrs. Johnson doing today? "Do you feel good? How is it going?" That loud. I slowed my speech down and I'm talking to her like she's a baby. 3 no-nos. Give context. Don't just launch into something as soon as somebody walks in the door. You've got to give them context. You can't say, "So what did you think of that?" and expect an answer. That frustrates, think about how frustrated you would be. I will have to say that my children do this to me. They will just launch off into something and they won't tell me. Their brain is thinking of what they wanted to say, and they've been wanting to tell me for 20 to 25 minutes or even longer. And they have the whole scenario worked out, and then they just launch off in the middle of it. And I'm like, "What in the world are you talking about? You've got to give me some kind of context for the question that you're asking me, or I'm not going to know what you're talking about." Also, remain positive and patient. For those individuals who have a hard time hearing, don't talk slower. Talk a little louder. Deepen your voice. And don't talk to them like they're a baby. All right. Okay. So with balance, I want you to think about older adults who might be prone to falls. It's one of the main reasons, and this is actually a question that a lot of you asked in the introduction videos. Why is it that, not about balance, but why is it that after falls, it seems that older adults deteriorate faster after they've had a fall? Loss of balance is one of the main factors that is responsible for those falls. And then that can also then lead to institutionalization and death. The top 3 reasons that people are institutionalized, hospitalized, is hip fracture, Alzheimer's disease, and incontinence. Okay, so those are reasons, and it can eventually lead to the person dying. And so we have to really focus on those balance issues. Previous falls are also a risk factor, because individuals who have fallen once think, "I'm going to fall again, and I'm just not going, and I'm going to alter how I walk because I'm afraid I'm going to fall." Or I may, the last time I was walking, I was using that cane, and that cane got wrapped up, and even though they know they need to be using the cane for their balance, they leave the cane behind because it was the cane that caused them to fall. You can have that fear of falling. I don't know if any of you have ever fallen in a particular place and you're like, "Oh my gosh, I fell there the last time. I'll probably do it again." it can increase that risk even more. The more you think about not falling, the more likely the individual is going to fall. Okay. And also, we have some situations where if they have vertigo or dizziness, that can exacerbate their fear of falling and also the risk of falling. So we have some fall prevention strategies. One is exercise. The other is eyeglasses. Believe it or not, eyeglasses. If you can see in front of you and see the stuff that is in your way, then you are more than likely going to avoid it. Or you may need to get bifocals, or you need to get rid of bifocals and only have general vision glasses and use bifocals for when you're reading. If you take off with your bifocals on and it's blurry down there and you're looking down and there's a toy on the floor and you don't see it and you trip, eyeglasses. Tai Chi, which is a great balance activity, having a prosthetic aid, having a shower chair or a bath bench. If the falls occur in the shower or in the bath, then sitting down to take care of their bathing needs is much better than not bathing at all. Sitting while grooming, so if they're getting ready or if they're brushing their teeth or if they are putting on deodorant, whatever it is, putting on socks, all that kind of stuff. Have sturdy step stools in the kitchen, making sure that your cell phone is ready, and also having some stability training, which we will address here in your assignment. Smell and taste, where we have a difference in our sensory receptors, and we might have a disease, or there might be an injury, or there might be toxins, which would be like smoking, which you will exacerbate the sense of smell and taste. And the biggest thing we are hearing is COVID, right? Where the coronavirus, this strain of the coronavirus, is really affecting some individuals' sense of smell and sense of taste. Dentures can also interfere with the taste, and cognitive changes can also be related to some kind of loss of their sense of smell. Looking at ways that we can compensate for this is maybe, if we've lost our sense of taste or a sense of smell, or it's diminished some, maybe choosing some different food choices, finding places that, or finding good dining partners, meaning basically if you think about, well, if I can't smell it and I can't taste it, I'm not going to eat it because, oops, that was good. I'm not going to eat it because I have absolutely no enjoyment in this whatsoever. And if we can help the individual along by saying, hey, why don't you come on out to dinner with me? And, let's try that new sushi restaurant. If you have that expansion of food choices, if we have people that are eating with us, we're going to be more than likely to continue to eat, as opposed to saying, well, you know what? I have something going on and I can't taste anything, so I'm not going to eat anything. And then our touch, a sense of touch, we need to have that, obviously, because we've got those pain receptors that have to alert us to something. If something is going on, we need to know. And there can be some psychological factors with pain. Many people will say, oh, no, I'm fine. Oh, no, it doesn't hurt, when it does. Oh, I'll be fine. That's stoicism. That's saying, I'm just not going to say anything about it because there's probably somebody who is, suffering more than I am, but really they're not. Okay. All right. So that's it for chapter 4. And what I want to do is show you what your assignment is for chapter 4. If you look here, chapter 4 assignment, what you're going to be doing is, as far as stability training programs are concerned, a stability training program is something like, if it's fall prevention for older adults. Are there any fall prevention programs that you know of? And if there are, where are they? Okay. Where did you find the program? I want you to give a summary of what the program is and what it covers, and whether there is any research or results that have occurred from the program to show that their stability training program has been successful. That's just going to be on, on their website. Okay. Don't think of this as I need to go out and do extra research. See if their website has any information on research that has been given that shows that this type of stability training program. So like Tai Chi, say if there's Tai Chi in the park at your local community center, and you found the information through the community center's website, start off with the Ohio Department of Aging. That's the best place to start, because once you get to the Ohio Department of Aging, I guarantee you, you are going to find a stability training program, okay? If you want to venture out a little bit to see if there's something that's close to you, then look at your local infrastructure. If you have a senior center that's in your area, if you have a community center, if you have a local church that offers maybe like a silver sneakers program that focuses on stability, making sure that they're addressing fall prevention or mobility exercises, those types of things. So this is the exercise, the assignment that you have for chapter 4. So what are the programs called? Where did you find the program? So what website or where are they located? And then tell me what the program is and what it's all about. And then tell me if they link to any research that shows that type of stability program has proven beneficial and what the results have been, okay? But mind you, remember, this is not go out to EBSCO and find yourself 5 research articles. That's not what this is about. Look on the site to see if they have anything cited, okay? All right, so that's chapter 4. I'm going to end this PowerPoint and this presentation with this, so this isn't too cumbersome. I think I'm sitting at probably close to an hour, aren't I? No, 45 minutes. So I'm going to go on into another Zoom presentation on chapter 5. I think that's it. All right, let me pull my stuff up here. I'm going to stop my sharing, and there I am. There's my lovely ceiling fan. All right, that's it. I'm going to put this on YouTube. I apologize for those of you who had issues with the password kind of giving you fits trying to get into the last Zoom session for chapters 1 and 2. That password is not anything that I can change. If I record it as a cloud recording, it automatically puts a password on it. I can't do anything to stop it. I went in, I checked all my settings, and that is a setting I cannot change. There are 2 password settings on there, and it says that it's been set by admin and it's blued out. Can't touch it. So that's why I'm going to go ahead. I'm recording this and I'm going to upload it to YouTube so you can easier get into it, hopefully, and not have to deal with a password. All right. So I will stop with this presentation and I will have my next one on chapter 5.